Perfect. Thank you all for joining us today. We're really excited about our October webinar and about sharing with you our speakers and our family partners. Today, we're going to focus on providing support to non-birthing partners, and then also have a panel discussion focused on our families who've had late preterm babies and term babies in the NICU. And I think on our next slide, we'll review our core team for the Family-Centered Care Task Force. I'm Colby Day. You guys have probably heard me talk before. I am an assistant professor in neonatology at the University of Rochester in New York. And then my co-chair, who is actually really the heart and soul of this task force, is Malati Balasundaram, who is an associate professor in neonatology at Stanford. And unfortunately, she had a family emergency today, so is unable to join us, but has put together the grand majority of this webinar. And so you'll see that we've kept her name on all the areas of the agenda that she was planning to participate with. And I just want to make sure she gets credit for all of her hard work that she's poured into this. And certainly not to be forgotten is Caroline Tony Noland, who makes all of our grand ideas actually happen. So we could not have any of this done without Caroline, and you'll hear the two of us talking today. We do have some partners. We're lucky enough to have some partners so far with our task force. We are aligned with the section on neonatal perinatal medicine's TCAN group, which is an interest group focused on trainees and early career neonatologists. We also are aligned with the CPQCC in California and with Neonatology Today. As for our agenda, so we're going to start with what I just introduced some of our folks on the actual task force, and then also give some updates from our different small groups as they've started their meetings over the summer. Caroline is going to do a Padlet demo for us, since I know myself included, that is not necessarily something that all of us have used before as a platform. And so it's nice for her to show us this new Q&A function that we're using on the Padlet so that we can encourage all of you to participate with that. We're very excited to have our speaker, who we will more formally introduce at the appropriate time, Dr. Patterson, and have a Q&A associated with that talk. And then we'll also have our family partner panel that I will moderate, that has a few questions that we absolutely want to ask of our family partners, but we also always encourage you to chat questions in. This is meant to be a very interactive forum. So please feel free to, throughout this webinar, chat in any thoughts or any questions you have. And then we'll have some closing remarks and some information on how to complete the feedback survey. And as we go over these group updates, if everyone could take just a moment to chat in your name and the institution where you are, that would be really helpful. And like I said, just start sending us your questions as you think of them as well. All right, and here I just want to show really, again, we couldn't be a family-centered care task force without our families, right? So we are lucky enough to have 17 family partners already that are fully integrated with this task force, and so excited about teaching us and helping us to really focus on family-centered care in the NICU and make this be a standard of care and not just a goal in the future for us. And so truly thank you to everyone who's helping us in this effort. Over to you, Caroline.
Thanks, Colby. So just to give a quick update, we have over 330 of you that are signed up on our task force listserv. If you scan this QR code, this will take you to our Padlet, which is essentially our huge Dropbox of all of our resources from past webinars. It has links to sign up for future webinars. If you aren't signed up already, we list out our family partners, how to tweet at us, some resources, and we're really excited for this because it's something that you can share, something that you can refer back to. If there was a slide deck that you really appreciated from the past webinar, it's here. And I'm excited because this can be shared with folks in the UK and Israel and Cambodia and Canada, across the US. This is a really international group, and we are so proud of all the work that you are doing in your hospitals. Something that we wanted to collate as well, though, is because we've had some really great Q&A sessions and some really wonderful resources that have been shared. Some of those resources, if they were mentioned directly in a webinar, are linked, like you can see from the September webinar here, there are a few resources that are linked directly there. If you scan this QR code, this light blue box, though, it will take you to our Q&A Padlet, which looks like this. So we have a couple of different columns here that are all different questions. And under each one, we've dropped in some questions from past webinars or some questions that have come up on the listserv. And some of them have been answered, some of them have not been answered. But we just wanted to show you quickly how to add a question or how to answer a question on here. So let's say if you have an answer to this question around paperwork and training, what did they do for family partners to do QI work if they're not paid? You just click add comment and you can type in and send your response. If you have another question around this topic, you click this plus sign and then you can just type your question here. You can send a link. You can click on link if there's a particular article that you want to upload that you found really helpful, you can do that. You can see we've linked to some documents here. So scroll down, take a look. This is an article, a PDF. This is example job descriptions for family advisors, family partner specialists, family peer support specialist. It's sort of a host of titles that we have for paid staff, family partners. So you can upload documents, you can link. We hope this is a really good resource for you as you continue to build your family-centered care committees and your family partnership councils. So if you have any questions, put them in the chat and I'll try to answer them as we go. And with that, I'm going to pass it over to group one. This is our small group one who's going to give a quick update.
Hi, I'm not sure if you can hear me. This is Elizabeth Simonton. Thumbs up. Okay, great. Thanks so much, Caroline. Doctors Fry and Matchut were scheduled to join, but they're busy with their clinical work. So I've stepped in. Our update is that we've had 2 meetings so far, one in June, the second in August. I actually just joined the group a couple weeks ago, so I didn't attend either, but happy to be the spokesperson today. Together, the group was getting to know a little bit more about the different centers, including the unique patient populations that they serve, the available resources, and also the areas that they have identified for improving family-centered care. They're also hearing about the different initiatives that the other units are doing and trying to incorporate some of those best practices, so to speak, in their work. And also inquiring a little bit more about whether there's a formal family partnership council within each of the units. And then we're meeting actually in just a few weeks to talk about metrics centered around family-centered care, and also identifying concrete goals that each center has to improve family-centered care. So that's the gist of it. And thanks so much for having us today.
Thank you, Elizabeth. Group 2. Darcy, are you on?
Yes, I'm here.
Hi.
Sorry.
You're fine.
Just came back from my call. So we have met twice. We first met in June, and then we again met in October. October 1 was a smaller group because I think it's like 2 days before the AAP National Conference. So people did not join the meeting. On the first meeting, we really talked about what are the units doing so far. So got to know all of them. I think 5 hospitals joined. So we talked about that. And we also talked about what one thing they would like to do and come up with a plan to progress the family-centered care in their unit and come back with the progress made as well as the issues or barriers they had. On the second meeting, it was the Florida Northwest group joined. I joined, as well as our parent partner, Catherine Huber, was there. So far in the Florida Northwest Hospital, they were trying to do skin-to-skin care, and they had some issues. They were trying to make the nurses as champions and providing some tokens for them to do better skin-to-skin early, increase the rate and the duration. And they did have some improvement, but when the token was taken away, the numbers dropped. So we as a group suggested that to have some handout to the parents, make the parents as champions and ask for it. And so that was something we talked. And they also have a lot of Hispanic families. So I suggested having the handouts in Spanish as well. And I was looking in our unit, we only have in English, so but we should translate in the Spanish. So that's something I was thinking when this came up as well. So that was a good discussion we had. In El Camino, we have done developmental care as the main thing. And so we are moving forward with that to have laminated developmental care for different stages at Stanford. Eilish Byrne and Melissa Scala together came up with this iRainbow, which described the babies in 6 stages. And so we were going to trial that out. And having the stages marked for every shift when the parents come, so they will get to know what they can do with their babies. And if they cannot finish all of them, the nurses can participate in that as well. So that's what we are working on. So that was the discussion, and we are planning to have our next meeting in January.
Thank you so much for that update. Group 3.
I'm happy to give an update for group 3. We are still in the beginning stages of our small grouphood, or however we want to put this. But we did have our first meeting early in the summer. We really spent most of it kind of introducing each other and talking about why we felt family-centered care is important and kind of what personal experiences we've had with that. I'll be honest, we didn't get into as much detail, it sounds like, as some of the other groups yet on what we are, our true objective goals are, other than trying to improve family-centered care culture. We have our next meeting in about 3 weeks, so at the beginning of November. And so I think that's going to be our first real working meeting to hear about what each group is wanting to accomplish over the next probably 3 to 6 months, and then what those long-term goals might be. And I'm hoping that with the variety that we've already heard in our own small group of kind of where different centers stand, we're going to be able to learn from some centers that have gotten farther in some areas and kind of see what challenges they had and what they were able to utilize to overcome those. So more to come from group 3 at our next check-in.
Thanks, Colby. For group 4, I'll give a quick update on this group. They've been able to meet once. I think it's always challenging to find a meeting time, especially when we're working across time zones, that everyone can be present or that most can be present. One center had a really active family-centered care committee and partnership council. 4 have, room to improve in those areas, and 2 still need to build theirs. So I think it's really great to have a mix of people in different stages, so that we can toss ideas around and see, what was successful for some folks, because it might work for other centers or might need to be tweaked a little bit. There were also goals around bringing in a paid family partner for a hospital and sort of how to do that. That's one of the reasons the job descriptions came up that's available on the Padlet, just as an example of what you might be able to present to hospital administration. And group 5.
I can talk about group 5. I'm Michelle Wrench. I'm a family partner with group 5. So we have had 3 meetings so far, once a month, the last 3 months. We're scheduled to meet regularly a week after each webinar. The next one is the end of October, and we want to acknowledge the level of commitment that our team members have by just sharing that some of them have attended the meetings while they're on service or post-call, and all of our members are very dedicated to the initiative. We're fortunate to have 2 family partners, Kira and myself, in our group. So far, we discussed and have focused on getting to know a little bit more about our different centers, especially from our international friend Rafi, about the unit practice regarding family-centered care. Everyone has completed their center's baseline context survey. We learned about their unique patient populations and identifying possible areas for improving family-centered care. One center has an active family-centered care or family partnership council, and the rest of them are either somewhat active or have yet to establish one. We hope to continue learning together in October. We're sharing our resources with one another on family-centered care, and we're continuing to work towards each center's particular goal.
Thank you so much, Michelle. And then just as a reminder, as sort of collective goals for this task force, we really want to increase the percentage of NICU specific family-centered care councils, family-centered care committees. Those are the interdisciplinary committees in each hospital to about 50% by next November. And then as well to increase the percentage of NICU family partnership, family advisory councils to 50% as well by next November. So this brings us to Dr. Patterson. We're really excited for this talk around providing support to non-birthing NICU partners. Dr. Patterson is an associate professor of clinical psychology at the Pilon School of Medicine at University of Pennsylvania. He is a licensed clinical psychologist at Children's Hospital of Philadelphia, CHOP, in the NICU. And as the director of psychosocial services, he is responsible for the oversight of the provision of really expert psychosocial care to families as they cope with the complexities associated with having a sick child. Welcome, Dr. Patterson.
There we go, on move. Thank you so much for the invitation and for participating in this organization. It's great that all the activity that you guys are doing, it's amazing. But thank you for the invitation. I'm going to share my screen. And then, let's see. And can everyone see the slide?
Mm-hmm.
All right, let's go back to the beginning. All right. So,
Dr. Patterson, we do have it on presenter mode, just for you to be aware, not on the big screen mode.
Okay. How's that? That's worse, right? Oh, I know. How about this? We'll do this one. How about that?
Perfect.
Okay.
Thank you.
Too many screens, too much technology. So again, thanks for the invitation. So in addition to my appointments at Penn and at CHOP, I'm also on the board of directors of the National Perinatal Association. So today I want to speak on providing support to non-birthing NICU parents. And just to give a little overview of the institution, for those of you who are not familiar with CHOP. So CHOP, we're located in Philadelphia. This is a picture of the outside of CHOP and a picture of the inside of CHOP. And at the NICU here at CHOP, we are a level 4 NICU. We have 98 beds. We transfer in babies up to 3 months of age. And we work with approximately between 1,200 and 1,300 babies per year. And we provide surgery and ECMO to the babies. We have approximately 400 nurses, approximately 40 neonatologists, and then a host of other supports: respiratory therapy, dietitian, OT/PT, speech, lactation, social work, psychology, child life, and chaplain, and a host of others. So that's just sort of give you an outline of the institution here at CHOP. So today I was going to be talking about non-birthing parents, but I guess I wanted to use this graphic as an example of what families might look like. So you can read all the different sort of arrows, and it can be a combination of 1, 2, or 3 of the different rays off of here. So I wanted to expand it because usually when we think of, or when some people think of non-birthing parents, they immediately think of dads. But I wanted to be a little broader in my discussion today to talk about families that have 2 moms, families that have 2 dads, families that have a mom and a dad, where there might have been a surrogate, there might have been an adoption, a gestational carrier. So I really wanted to try to broaden the conversation in my allotted time, of course, to talk about a broader range of what a family might look like. So again, as I said, I want to talk about the non-birth parent. And sometimes the non-birth parent is a mom, and sometimes the non-birth parent is a dad. And sometimes they are biologically related, and sometimes they are not. So that's just sort of give you an idea of what I wanted to speak about. But stepping back for a minute, I guess as a psychologist, and when I think about supporting parents and certainly non-birth parents, I think about why people get pregnant. And usually if I'm in person, I would usually, pause and ask the audience to give responses. Virtually, it's a little tougher. But again, it can, I guess, vary from, this is sort of something that, people do. It might be family pressure. There might be a financial reason to get pregnant. So you have a range of more positive, and then sometimes you have the negative reasons that might be, again, pressure from families. It might be a way to stay connected with an individual. It might be a result of, incest or rape. So again, there's a wide range of reasons why people become pregnant. And I think as a psychologist, as a psychosocial person, I always think about when I walk into the room to get an understanding of what this pregnancy means to the family. Again, sometimes the pregnancy, it's been many years of trying to get pregnant. So there's a lot of pressure, on having this be the pregnancy. Also, I think about, in my experience, this is what families imagine having a baby might be like, or the birthing process might be like. And if you look, everybody is very happy, and there's smiles, and there are no tubes, there's no wires. But unfortunately, in my world, this is the reality of what families experience. You have ECMO, you have, Billy lights, you have tubes and wires. So again, understanding that, walking into the NICU is a very traumatic experience for families. And if we look at just some of the rates of depression, post-traumatic stress disorder, and perinatal mood and anxiety disorders, you can see differences across NICU parents and then non-NICU parents. And when I talk to parents, I get a wide variety of emotions that they express, from happy to sad, a sense of loss. There's anger, there's feeling overwhelmed, there's shame, there's hopelessness, sadness, isolation. So a wide variety of feelings that come into play. And again, thinking about the different roles, we have fathers and their roles, and some of the myths and truths that sort of come out that I've learned over the years that society has put upon them. They think about fathers as providers, the emotional rock. They need to not be emotional, right? They need to be detached so they can help the family. So these are some of the pressures that some of the non-birth parents might feel their role is in terms of the birth of a child. And again, with men, a lot of times it's big boys don't cry, right? They're asking about how is your wife doing? How's the mom doing? How's the family holding up? And really not talking about how they are and what their experience was like as a result of this pregnancy and of this birth. 2 quotes that I like to share is, as a dad, I feel like we are often overlooked in the family picture. I was terrified when we had our son 7 weeks early. And it was, as a result, he created a Pop-Up a Preemies website. And then there's Jeff Stimson, who stated, it's not a matter of a good hand, it's a matter of a bad hand played well. So broadening and thinking about, different types of families, we wonder if some of the emotions, and many of the emotions are shared by the non-birth parent, but we wonder if there are some that are unique and some that are shared, because we know that, with all families, no matter what the makeup, there are many layers that come into play. There's the institution where you're being cared for. There's the race, there's the ethnicity, of the family and the family members. There's the age, there's how they identify. So there are a lot of different layers. And again, these are some of the emotions that, when I spoke to some of the parents where there were two moms or two dads, these are some of the feelings that came up. They talked about, the non-birth parent being envious or jealous, that, they feel like, the baby might like them, might like the birthing parent more than them because of the breastfeeding, because of that closeness. When I talked to one of the dads in the family, they talked about feeling unimportant or invisible or unequal or as an outsider. And many times they felt that they were being judged, as not one of the families that might ordinarily come into the hospital as two dads. Again, in situations where there was a donor, a surrogate, or gestational carrier, they talked about being worried or scared about the donor egg. There was some background in genetic testing, but what is this, donor egg? What is going to bring into the family? What's it going to be like? In terms of the donor sperm, the same idea. Thinking about, the surrogate, the mental health or the physical health of the surrogate. How is that going to impact, the birth or the gestational period of their child? So again, a lot of worries that, in the family where there's a mother and a father that are genetically connected to the family. When we have families where there are two moms or two dads, and, there might be a genetic connection or not, you have some of these worries come up. There is a fear of genetic complications. So sometimes when I talk to some of the families, when they were choosing between, which mom's egg to use, there was a fear about, genetic complications. Well, which egg should we use? Or in terms of which sperm should we use? Or choosing, a donor egg or donor sperm. What is that going to mean in terms of, the genetic makeup and how it's going to combine, with the egg or the sperm? It was interesting when I talked with two moms, we talked about empathy. And it was very interesting to find out that, in terms of going through the process of birthing together, the mom who was not the birthing mom talked about, she felt like she had a special empathy to the birth mom, knowing, a woman's body and some of the things that might be going on with her body, especially if she had carried another child. And that was very, very interesting. And that doesn't always happen, in families where there is a mother and a father, or when there are two dads. Again, I think also, there's the stereotype of, it might be harder for the non-birth parent to ask for help, right? Because all the focus is on the birthing parent. So maybe there's some hesitation to express emotion for fear that, there might not be any support for you. And then certainly in the case, specifically with the two dads, we talked about, and also the two moms, we talked about sometimes being overwhelmed by the financial investment and commitment to going through the process, of, finding a gestational carrier, finding an egg donor, finding a sperm donor. There's a lot of things that go along with that, not all families, have to manage. And I think in some of my conversations, we talked about, the range of interactions, and I said it can vary depending upon certainly, race, ethnicity, where you are, the people you're dealing with. But in the best case scenario, again, when I spoke with the dads, I was very surprised, and I don't know if other folks, in the audience have found hospitals. They had a surrogate coordinator. So their experience was amazing. From the day that they had connected with the hospital saying that they wanted to, have their child at their hospital, they were connected with a surrogate coordinator who sort of walked them through, the whole process. With the two moms, their experience, the hospital was very welcoming, which was really wonderful. And certainly they, with the mom and the dad, they found the same thing. So those are the best case scenarios. In the worst case scenarios, from my conversations with another set of dads, they talked about the staff and some interactions where their role as a parent was trivialized, and they didn't truly recognize that they were the dads of this baby, and there was some some homophobia that came to light, and it was interesting. Even though there was a biological connection to the babies, they still felt like they were sort of outsiders to that process. Again, with the two moms, there still was some phobia involved, and there was a hard time at some points understanding that they were two moms, that they weren't sisters or it wasn't an aunt. So they felt like they continued to have to sort of come out every time they had an interaction with a new provider, explaining who they were and what their relationship was to the child. And then with the mom and dad, there was the idea that everything was focused on the mom, and the dad was sort of like an afterthought, like he was disregarded, that he really wasn't part of the process, and he really didn't have a role to play. So it was very interesting, again, in my interviews with some of these families. So you think about, and if we do have some non-birth parents in the audience, I wasn't sure, you talk about, well, what can you do? And as a non-birth parent, some of the things you can do is wash the pump supplies, right? Help, the nurse or staff or the birth parent wash the baby, hold the baby, change the baby. Take time to sing, to read, to talk, with the baby. Support your partner. Talk with your partner. See how your partner is managing, with all the ups and downs, of their experience. And then it's a partner parent, when relevant. Some of those bumps along the roads, it's important to be there. In terms of non-specific things, try to be a buffer with the staff, with other families, relatives, and friends. Again, help with the health insurance if that's something that's needed. Help care for other children if you do have other children. If you need to go to work, it's okay. Go to work. Play your role in the larger family. If you can manage the food train or the meal train, that is always great. And then also encourage self-care both for yourself as well as for your partner. In terms of providers, I was thinking, and the list just went on and on and on. So these are some of the ones that I wanted to highlight. But as a provider, if you're not sure about who's in the room and their relationship with the baby, just ask. Right? How are you related? How are you connected with the baby? I'm mom. I'm mom. I'm dad. Just ask. Try to explain the role of the team. Not everyone is medically savvy, and they don't know what a fellow is or what an NP or PA or even attending is. So explain the roles of the team, and offer some anticipatory guidance about what this experience might look like. Try to help connect the family with appropriate staff within the hospital or within the unit. Certainly encourage self-care for all family members, and help them find folks from the extended family that can help support the family. Always you want to take pictures to mark the milestones that the infant makes, that the family makes. And then for the psychosocial staff, when you're working with family, certainly acknowledge the trauma and the emotional impact that this experience has on the child. Try to offer reputable social media links, Instagram, podcasts. There are a lot out there that these families can connect with, so they don't feel so isolated. I know in COVID, families really felt isolated, and I really tried to connect them with a number of resources online where they could feel connected. And then certainly recommend community supports if that is something that the family is interested in. Again, when you're working with families, always remember that they're not always on the same page, that they're experiencing this hospitalization differently. They all react differently. Sadness and post-traumatic stress and the perinatal mood and anxiety disorders can come out in many different ways. It can come out as being prickly, right? Being tired, being sad, being exhausted, getting angry easier, being hypervigilant. So it can come out in many different ways. So again, as a staff and as a partner, we need to remember that. Just to discuss the impact of the grief and loss of the normal pregnancy that they might have imagined or even had, with the previous child. And certainly acknowledge society's message, related to gender, the couple, the family structure, race, and ethnicity, because all that really plays a part. And sometimes it's kind of like the elephant in the room. Nobody wants to talk about it, but everybody knows, it plays a role. And certainly really encourage families about different ways to communicate when words fail. So that can be, touch. It can be, art therapy, journaling, Again, talking is great, but there are also other ways to communicate, how you're feeling and express your emotions. And again, trying to create special moments for the non-birth parent, encourage them to hold the baby, to speak to the baby, to bathe them, to change them, to participate, and to take pictures. The one quote that I found that I really liked to sort of end this presentation with was, the inability of some people to verbally express their pain and emotional reactions should not be taken as a sign that they suffer any less. And I think sometimes, people sort of fall between the cracks or sort of they suffer in silence. And I think, we really need to work harder on reaching out and checking in with people, more often. So I want to thank again everyone for their time and attention, and certainly thanking the task force for the invitation. But I also would like to thank the families that I was able to interview to collect the information for this presentation. And I see screen, and there we go.
Thank you so much for sharing that. Yeah, I would love to open it up to see if there are specific questions that folks have for Dr. Patterson. Feel free to type them in the chat, or you can come off mute. We have one. Do you offer a psychologist in the NICU for parents at CHOP?
Yes, thank you very much for your question. So yes, at CHOP, we're very fortunate to have a few psychologists. Altogether, in terms of FTEs, we probably have maybe 1.5 to 2 psychologists. I'm one of the psychologists that's 50% clinical time in terms of working with parents. The other time is academic and programmatic. But we also have other psychologists who split their time between the NICU and other units within the hospital. So again, we're very fortunate to be able to have psychological services in our NICU.
Dr. Patterson, that is wonderful that you are able to have those services. I think it's something that many of us aspire to in our hospitals. I'm curious a little bit about the logistics of how you use the psychologists in your unit, particularly whether you approach or your group approaches all families, or if you wait for families to reach out saying that they need help, or if there are specific screens that are done, and if so, who performs those screens?
Yes, great. Yeah, thank you for the question. So in our NICU, referral comes in a number of ways. The medical team will usually connect with the social worker, and then the social worker, they do their assessment and talk to the families, and then ask the family about, having a psychologist come and speak with them. We don't screen. We're working on universal screening. But we have not sort of nailed that down in terms of logistics. We're a freestanding pediatric hospital, and we don't have supports or a system of support for adults. So if one of the family members needed adult care, we would have to refer out. We don't have adult psychiatry to manage medication, so we're a little limited in that way. But we do have psychologists. Like I said, social work does their family assessment. And they connect with all families. They do a great job, and they usually reach out to us as a result of that. Sometimes we get referrals from, again, bedside nurses or other medical care providers. But again, we usually have the social workers go out and do an assessment. There are other families, which is fantastic, who come in and say, "Hey, do you have a psychologist on staff? I'd love to, speak with them." And then we would get, connected with that way. Now, just to go back to the first part of your question, it is unique that, some institutions have a psychologist. There is some information on the web about how to encourage your hospital to get a psychologist. There's information on the National Perinatal Association. There's a link, I think it's to support for NICU parents, and it gives a job description, and it gives sort of a whole sort of PR package about how to ask your institution to support a psychologist in the hospital. And I don't know if there's anyone from that group that can put it in the chat, the link to that information. But again, it really helps you bring a package of information to your organization to help convince them.
I'm going to do some sleuthing for that, because I don't think any of us are very good at that aspect of.
I can send you a packet of information that gives you that. It's a really great website. I know Mike Heinen, Sue Hall, and some folks from NPA did a lot of work to pull this information together, just because we were really trying to get the word out about psychology, what we can do and how we can be helpful, to medical staff as well as for parents.
That would be wonderful. We can put it on our Padlet resources for everyone to see. Thank you.
Yeah.
We have another comment, just a really great idea about using Epic to allow those sticky notes so that you can make the different family member roles really clearly visible to all staff. Angela also said that their hospital prints pictures of the parents doing skin to skin. And so that's, really clear communication for all staff as well. Another question from Sarah, can you talk about how you bridge psychology care after discharge?
Yes, that's a great question. It's very challenging, I'll say, because providers are very difficult to find. We work really hard to create a list of providers. We definitely, I know we take advantage of the Postpartum Support International link, where you type in the zip code and then you get providers in certain areas of the country. And I think maybe they're moving towards the world, but it's really trying to create a network. I think a PSI is a good place to start, but just creating a network. Again, many hospitals, they treat not only families in their area, but sometimes out of state, and it's really hard to find those providers. But usually when families are maybe what I think midway in, I usually start thinking about where they live and encouraging them to either look through their insurance, or I try to help find them providers, in their area. There is a National Network of NICU Psychologists. That's another link for psychologists. Thank you.
And then an add-on for families who may lack insurance or may not be able to afford psychosocial support after discharge. Are there any resources that CHOP has for these families?
Well, not necessarily CHOP, but I would say I usually try to link them to the internet. There are a lot of organizations and foundations that have mentors. Graham's Foundation, run by Nick and Jen Hall. They have, sort of mentor relationships. I know PSI does that. I know NPA. So there are a lot of foundations and organizations that have resources. Hand to Hold has some really nice resources where they have mentor programs. So I usually reach out to those groups to help me, because not everyone is local. If they don't have insurance, I usually try to, again, find things on the internet, but also I try to go through sort of the local city agencies to find community groups that offer a free or low fee services. Yeah, thanks for feeding the chat. That's great.
Another comment, Project NICU has connections with Better Health Online. I know I've seen them advertised on Instagram. So they're able to get free counseling for NICU families. And then Hope for HIE families, this is from Betsy. They also have a social worker on staff to connect folks to therapy services. PSI has a lot of online support groups, which is great. I know sort of across the US, there's also right now a shortage of mental health providers. And so I think that finding support may be even more challenging for families. And so being aware of that is really critical.
It really is. Usually, I've been trying, and some wait lists are 2 to 3 months. And families can't wait 2 to 3 months.
Exactly, yeah. Any other final questions for Dr. Patterson before we move on to our family panel? And I just want to say from my part, this has been really great to see and to hear so many different family structures represented and celebrated, and then making sure that we as healthcare providers are doing our best to ensure that families feel welcome into the NICU. It's hard enough to align transportation and time off work and care for other children or other responsibilities. It's hard enough to make it into the NICU. And so when family members are able to come, we really want to make sure that we're doing our best to ensure that they are supported. So thank you so much for your talk.
All right. Thank you so much.
Let me just get my screen shared up and I'll pass it to Colby.
Wonderful. And I echo those comments. Thank you so much for that talk, Dr. Patterson. We're going to transition over to our family partner panel, and we are excited to have a little bit different focus than we've had so far in the previous panels. I think that one mistake that we can make sometimes as providers in the NICU is to get tunnel vision on focusing too much on one patient population and one patient population and family population's experience. And I think a lot of times that ends up being some of our smallest babies. And it comes from a place of love from providers, because we know that those families have a long stay in the NICU. But we certainly don't want to detract from the experience that all of our other NICU patients have and their families have. And so we felt very strongly about making sure that we are inclusive of the NICU experience for all families. And we've had some great feedback from some of our participants on this call today to really encourage us as well to have that increased focus. And so today we're going to be talking with our family partners about the experience of families who've had late preterm babies and term babies in the NICU. We did originally have 6 family partners that we were welcoming today. Unfortunately, Shasha Chu and Dr. Theresa Urbina had family emergencies as well come up, and so are unable to join us, but have provided us with some comments that we can share throughout the panel discussion. But as we've done with our other partner panels, I'd like to really give each of our panelists the chance to introduce themselves and give a little bit of a summary about what their experience has been with the NICU. I think it, at least for me, speaks so strongly to hear in their words why they're passionate about family-centered care and participating. And so for each of our panelists that are here with us today, I would ask that we start with a small introduction and then also the answering of this first question here. So why do you think family-centered care and partnering with families in the NICU is important? And let's see, just for the sake of efficiency, I'm going to go on this slide in the order that it's there. So if we could hear from Dr. Amanda Yeaton Massey first, that would be great. And please chat in comments. Hi.
Hi, I'm Amanda Yeaton Massey. I am a maternal fetal medicine specialist at UCSF and have 2 NICU kiddos. And actually, Shasha, my wife, our kids gave her a cold, so she's lying on the couch coughing. But we had 2 kiddos and each carried one. Shasha did IVF and carried our son Simon, who I had the experience of being a non-birthing parent for in the ICN or NICU. And then we somehow had like a double header, and our daughter Willow, who I carried, also was in the NICU. And, you know, for us, we had a really complicated first year with Simon. He was in the NICU and then spent like a lot of his first year of life in and out of the PICU and had many different surgeries. And so I had the experience of being his mom and also not being recognized as his mom, and folks being kind of confused because we were an interracial couple and we were 2 moms, and often I think people didn't know who I was or what to make of me. And instead of asking, they assumed that I was some stranger who wasn't welcome. And I remember after our son's first surgery, when he was 8 weeks old, I was turned away at the front desk of the NICU, and they said, "Oh, mom can come in, but you can't." And I said, "I am mom too." The 2 of us had gone up to the desk. And for me, that was this very terrible experience that I think overshadowed a lot of the wonderful things that happened for our family in the NICU, because I would say, you know, in broad strokes, we had excellent care. But for me, that really stood out. And I brought it up to the team and just said, listen, I hope that this never, ever happens to another family, because, you know, I'm somebody who's very familiar with the healthcare system and knew how to advocate for myself and get in. But, you know, I think many people would have turned around and felt very ashamed and sad. And yeah, so for me, that's really a big piece of why this is important to me. And I'm excited to be here. And actually, Malati took care of our daughter Willow, and that's how I got connected to this. She had HIE, so I'm very grateful to Hope for HIE and yeah, to all the great care our family has gotten in the NICU.
Thank you so much for sharing. Let's hear from Michelle Wrench next on your experience and why you think family-centered care and partnering with families is important.
Hi, everyone. I have 3 daughters, and all 3 were in the NICU. Family-centered care is very important because it allows us as parents to connect with our infants early on in their life when we feel like we are not having a lot of control, or maybe don't feel like our desires and our hopes for first-time parenting or even parenting later on is changed from what we expected. So family-centered care helps parents to bond with their children and create an everlasting relationship from the beginning. In speaking in regards to having late preterm infants, I have one of my daughters who was born late preterm at 35 and 0. I had previously had my twins at 30 weeks, so I thought 35 and 0, great, I'll just keep her fed and take her home. But she had other plans, so ended up in the NICU on ventilatory support and spent some time there in the NICU recovering. So I think that one of the hardest aspects for having a late preterm infant is sort of expecting to have this normal, healthy baby who's just a little bit early and might just need a little bit of care, but not as extensive a care as sometimes late preterm infants require. And also the difference with family and friends and how they may be supporting you through a late preterm infant delivery because they see a baby who looks like they should be at home eating and carrying on as a full-term baby would, but in fact, we know that they're not and that they need a lot of extra help. So I think that was very different for my husband and I to experience a late preterm after our first 30-week twins, and helped us really get an appreciation for the fact that late preterm parents really do go through so much trauma, just like those early born premature infant parents do.
Thank you, Michelle, for sharing. If we could hear from Dr. Vishal Kapadia, and I'm so sorry if I said your name wrong.
No, you're good.
Okay, good. All right, thanks.
Yeah, hello everybody. I'm excited to be here. My name is Vishal Kapadia. By trade, I'm a palliative care physician, and I've taken care of these kiddos at the NICU in the past. I think our NICU journey, actually first, I just wanted to say thank you to Dr. Patterson, because a lot of the things that he said really resonated to the experiences that at least I felt, and what I've learned other NICU families have felt too. So if you don't trust him, trust me saying that I trust him, because that was very powerful. My NICU journey actually started before my kids were born. We were having twin girls. One has Down syndrome. One is a kid with Down syndrome, but that wasn't the big issue. She also had growth restriction, and then she had end-diastolic flow from the placenta, and really we were not sure if she was going to survive or not to delivery. We had a lot of complicated decisions that we were needing to make, and it was a very tough process before they were born. But both girls were born at 32 weeks. The younger, by 2 minutes, was in the NICU for about 6 weeks. However, my daughter Yeaton, she was in the NICU for about 4.5 months. And to experience all that from before delivery, during delivery, and after delivery, it was such an overwhelming experience. And it's, again, it was very traumatic. There's many times during the NICU stay where I was very grateful I was a medical professional, that I was able to advocate for myself and for my family. I worry about the families who don't have that knowledge or don't have that experience or don't know how to advocate for themselves. So I am really grateful for that, that I was able to, but again, still worried about how other families will navigate through this process. And why, having family-centered care is very important is that I can speak for myself, but from all the NICU families that I spoke to, this is one of the most difficult or most challenging times in our lives, right? There's going to be more challenges as time goes on. Please don't get me wrong. That was one of the worst experiences I've ever had. And I've gone through medical school, residency, fellowships. I had attendings yell at me. We had all this stuff here, but this was really the hardest thing I've ever done. And whenever you do something very hard or something that you're kind of stuck in a bind, or you just have a million emotions in your mind, having any support or guidance means so much. And that's why having family-centered care is extremely important, to us NICU parents and us, I think, in general, because ways that we could support one another. So again, support provider to provider, support provider to NICU parent, it goes a long way and lasts for the rest of our lives. What has impacted me during a NICU stay is impacting me right now, which is over a year ago. And I feel like this is my stay, my experience is a life-altering event. And any help, any support that is provided really will last us, I think, for my entire life. And that's why that's why that's very important to me.
Thank you, Dr. Kapadia, for sharing. Can we also hear from Betsy Pilon?
Thank you. So I am the Executive Director of Hope for HIE, but I have not been that for my entire motherhood. My journey started 10 years ago with my son, Max. He was born at 37 weeks in our community hospital. I had worked for the health system actually that he was delivered into in a marketing role. And I knew that there was a transfer process where if kids that needed more intensive care would be transferred to the main hospital. So that was our situation. I had never heard of HIE. He was born with HIE. He stopped moving and was thankfully a kick count save via emergency C-section. Definitely had never heard of cooling the brain of a baby. That sounded like science fiction, but that was our situation. So we received excellent care, excellent clinical care. But, when you get to a certain point, this was my first pregnancy, all the, all the literature, all the education, all the classes that you can take prenatally talks about a NICU stay that's potential for prematurity. And so, after you get to a certain point, you go, oh, this is smooth sailing. If they're going to be born at this point, maybe they'll have wet lungs or, need a few days if there's going to be a complication. And obviously being thrown into a neuro NICU situation totally rocked me to my core, as it does for many of our families. And, we had what I know in NICU time is a relatively short course. But myself, like other families in the HIE world and other non-premature situations, there's a lot, and traditionally has been a lot of support for preemie families. And when you're kind of thrown outside of that mix and you're hearing comments of how big your baby is, and then you're hearing your baby is one of the sickest in the NICU, this is the pod for the really, really sick babies, and you're not fitting into this, societal expectation of what this NICU experience is to be, and dealing with the trauma of going through not being able to touch your baby because they're cold for 3 days, and going through a cool down and rewarm and lots of levels going crazy. And so for Max, it was, very arduous in the first few days. And then it was, we entered the realm of wait and see, which, you get an MRI for HIE, variety of days that, are best practice. And the MRI is used to counsel families on what potential impacts could happen. And for many, like Max, there was a lot of gray area. He was a moderate case, so right in the middle of where he was. And so, we went through this, and when it's, for us, it was our baby's brain, the, core function of it can affect so many different things of who he is, who he could be. during the course, like I said, we had great clinical care. One of the big gap areas for us was when we came to discharge, and I had asked for any support services, anything to connect me to other families that have gone through this. I was met with, no, we don't have anyone we can have you talk to, and don't go home and Google. And so, of course, I am a terrible listener sometimes. And I went home and I Googled and I found families, and I found 200 families from all around the world in a small little Facebook group at the time. And they became my lifeline because there was no other information. There was no educational information. We were encouraged in the NICU to feed and which was a stressor because he was sluggish to feed because he's overcoming a neurological injury. And it wasn't the typical preemies need some more time. This is Max's, is fuller term. So that certainly, there was just a lot of those questions in that experience that were unanswered until finding others that had gone through it. And for me, my big 3 questions I talk about all the time, when we discharged from the NICU, the realm of disability didn't necessarily scare me. It was more so the relationships that we have with people in our lives. My husband and I, can our relationship last if we face significant disabilities with our son? Because I know that the statistics aren't great out there. Can I maintain employment because I really enjoyed having a career? Can we keep our house? Can we, make this work, whatever the future looks like? So it was very, very, finding people that could answer those questions and show living examples was absolutely critically important to my healing. And to really drove, the creation of Hope for HA, off of Facebook into the nonprofit section to ensure that no family had to find scary medical journals and predatory birth attorneys online. So, and that has been the drive for me over the past several years. And I have a wonderful 10-year-old son, Max, now, who would tell you that he's living his best life every day. Playing the trombone, in the STEM club now, and he has impacts from his HIE, but we're very proud of who he is. And I'm grateful for the importance of family-centered care for all experiences, and everyone moving that forward to bring that equity to all families in the NICU. Thank you.
Thank you, Betsy. I am going to read something that Dr. Theresa Urbina sent to us. As well as I said, she had a family emergency and wasn't able to join us, but she is a NICU fellow in DC. And she had a baby born with congenital heart disease, the double outlet right ventricle. And so in answer to this first question, she said that she feels family-centered care is so important because as a parent, you have absolutely no control when your baby is in the ICU. And when the medical team actively works to include you as a parent, even though you can't make your baby better or do the amazing work that the doctors, nurses, and ancillary staff are doing, it makes you feel like you're still the parent. And so she wanted to make sure that we shared her point of view for that first question. For our second question, I'm going to just open it up to each of the 4 of you to kind of respond as you want. But our question for you is, what is one or what are a few things that you feel healthcare providers should know or improve upon with respect to family-centered care?
I would say from the, from the HIE perspective, like being up on the latest research on how you can implement holding sooner, feeding sooner, things that are really important for more of that normative experience in the NICU, and being thoughtful again to the bias that is out there, the baggage that everyone carries in to the NICU with them. I mean, most people, the trauma, it begins at delivery and then it just continues throughout until you get to discharge and then you're processing. So I think having that understanding of families that they had baggage before they walked in the door to the NICU and how they're, I love Dr. Patterson talking about, being mindful of, people's, they might not tell you everything, but, to be mindful of the fact that people do have those lived experiences and a kind of level setting accordingly.
I think to go on top of that, I mean, in addition to that, excuse me, is that we have a lot of emotions, right? There's a lot of baggage, absolutely, but there's a lot of distress, stress, anger, frustration, like how Dr. Patterson portrayed it. And one thing that I've been trying to show, and I think a lot of people are trying to show, is that, as NICU providers, to take on all that emotion by someone, you'll just be fried by the end of the day, right? But leaving it absent and not addressing it doesn't allow for very good family-centered care. So how do we bridge that gap? And I think a lot of it relies on communication. And how do we communicate? How do we demonstrate empathy? How do we show that we care? And, by showing that we care, it shows how we support one another. You could be the smartest person in the room, but if I don't feel like, hey, you really care about my daughters, care about us, I'm not gonna really rely on the information you give me as much as compared to, it's like, hey, this person really understands that I'm hurt right now. They really understand that I'm sad, I'm depressed, that I'm miserable. I think being able to show that empathy through communication can be very helpful. Another thing, and there is another NICU parent by the name of Kimberly Novod, and she actually tweeted this, and I completely resonate with this, that when we talk about the gravity of the situation, I know we could talk about stories, we could talk about our experiences, and I think for me, I appreciate all of you being here to hear what we have to say. For NICU parents, this is, again, a life-altering event, that in the NICU, we are there because we have to, because that's our kid. We are resilient not because we want to, but because we have to. And when we are in this phase, right, at the end of the day, as NICU providers and NICU teams, that you could go home, you could change jobs, you could do whatever you can. And again, not to say you don't care, because I know you absolutely care about your families and your kiddos. For us, that's our whole life, right? Our life revolves around like going to the NICU, being in the NICU, spending time with our kids and things like that. So that's why there's a lot more baggage that comes before, but also a lot of baggage that comes during, because we may not get the self-care we need. We may not get the psychosocial support that we need. And just being aware and cognizant of, some of the things we may go to, and showing empathy through proper communication could really go a long way.
A couple of things that I would add, I think normalizing the experience for families, just saying like, hey, this is a hard thing that you're going through. You're going to experience a lot of emotions. Some people feel them now, some people feel them later. And if you need a space to talk, I think even just holding that space as a person who is caring for the family, not even necessarily with mental health expertise, but just, saying, I care about you. We realize that there are all of these medical things happening and also all of these psychosocial things. So I think even just, naming that and asking about it. And I think another concrete thing that's super important that often gets left out that our family experience is not having adequate discharge planning. You go from having this like super high intensity experience to sometimes going home from having had a one-on-one nurse to being alone with your child. And so I think, going through the family, like just saying like, hey, it's a big change to go home. If you have questions, this is where you call. You're going to have questions. That's okay. You know how to do this, and it's scary. So I think, just kind of naming that for families and helping people understand that you can be a good parent and be scared.
I just want to echo a little bit more about what Vishal and Amanda talked about, starting with the level of empathy that we're providing these families, and specifically today, all NICU families. I'm a NICU nurse, and I was a NICU nurse for 10 years before I had my preterm children. So my perspective at the bedside changed dramatically after I had my twins, as you would expect that it would. So providing that level of empathy that Amanda was touching on, and Vishal, that this is really like, this is the worst day of your life, the day your kids are born. And there, you might have a lot of other of those sort of worst days of your life. But just having your staff be able to tap into that and know that all these emotions of sadness and frustration and maybe not, you know, feeling comfortable opening up to everyone, or nervousness about taking care of their babies, that can all just be parts of them experiencing a really awful time in their life, or their relationship with their partner. You know, oftentimes in any kind of an ICU situation, your relationship with your partner is at its most fragile because you're both going through the hardest time of your life together with your child that you both love more than anything. So I think just getting everybody sort of to wrap their mind, everyone on the care team to wrap their mind around the level of emotion that these parents experience every single day, and not just when they walk through the doors, but they're experiencing it every moment of every day. And you know, to sort of shadow what Amanda had said, that as parents, we take this experience and the trauma home with us. And sometimes we're really great at holding it together when we're in the most stressful situation. But then when you go home, everything sort of like becomes, you become more aware of everything that you've gone through. And sometimes that's when it gets really difficult for parents emotionally. So having that great emotional support after discharge, and letting parents know ahead of time before they're discharged that the emotions might get even harder as you go home, because you're actually going to have time to take a breath of relief, but also finally tap into what you've been feeling all along, and to really have that post-discharge emotional support, I think, is so valuable for any parents of the ICU child.
I'm going to add on one of Theresa's responses too. So in talking through some of the things that she would want medical professionals to know, I think she really wanted to hit on the other stressors that may be happening in the lives of families, and maybe impacting not only their ability to be physically present, but also to be emotionally and mentally present at the bedside for their baby that's in the NICU. And she commented that one of the hardest parts of her experience with her son in the ICU was knowing that to be with him in the cardiac ICU, she was not able to be with her other child at home, and vice versa. And I will add to that, being very cognizant of terminology that we use and statements that we make to families. I'll say I had twins, and I had one in the NICU and one at home, and nothing cut more deeply than having someone call and say, I missed you on rounds today. And really I was at home with my other child who'd just been born, but it affects you. It makes you feel guilty that you aren't there for the child that's in the ICU. And so they're well-intentioned statements, but I think it goes to us needing to be very cognizant of the things that we say to parents and how they could be interpreted in the moment. Amanda, I had one question for you in particular. I know that you spoke about, and forgive me if I get the details wrong, but I think you spoke about your experience with your first child, whom you were the non-birthing mom for. I'm wondering with your second child, if you had a similar experience, or if you came to the hospital better equipped with ways to prepare the hospital staff for knowing both of your roles in your second child's, stay in the hospital, or whether you had any similar experiences.
So I guess like the delivery experiences were so different. So with our first son, he had a congenital brain anomaly that we knew about. And so we knew he was going to go to the NICU, and we knew that he was going to be there, and his delivery was not particularly dramatic. But then, he had surgery, and I think that was where they didn't want to let me in after his surgery because they thought that I was not a family member. And, you know, we had subsequent admissions and surgeries after that where I was like very clear before we got admitted, hey, this was a thing, like, please don't let it happen again. But with our daughter's delivery, it was just such a debacle, and she unexpectedly had HIEs. I think it was kind of this like, I don't know, there's so much I don't remember about that experience. And I, you know, like my wife and I react very differently to things. Like she was very angry, and that was like her primary experience, or like her primary emotion that she was sharing with the outside world when our daughter was born. And so I asked her about this actually, just in terms of like her experience, and she was like, you know, I didn't really feel like that much around being a non-birthing parent in the NICU. So I think like once people knew us and we had been kind of hanging out for a long time in these ICU environments and they were familiar with us, we became moms. You know, nobody knows your name, they just call you moms, and that was fine. And I liked that. So yeah, it was kind of a circular answer to your question, but it was only really that one bad experience. And I made a pretty big stink about it, and I think it fixed it.
Good for you. I'm glad you made us think about it. Hopefully you made it not happen for other families that were coming through after you. So
yeah, I hope so too. And I just like, as like another anecdote aside, I actually was I delivered, so I'm an OBGYN, I delivered where I trained. So I like knew all the people. So that was kind of additionally weird. So I had ways to sort of back channel this and just say like, hey, this thing happened to me as somebody who works here, who is known. And I was able to work with our social workers and with some of the staff to do some education around family composition. And so I think that did help others going forward.
I just want to add on to what Amanda was saying about how well she advocated for herself and for her partner. Oftentimes when our children have been hospitalized, my husband and I are like so thankful that at least one of us is in the medical community so that we feel comfortable advocating. And we often wonder, what do families do that have no one in the medical field to advocate or feel comfortable advocating? And so, you know, one of the takeaways from that I take with me every day to work, and when we run our family-centered care parent exchange meetings, which is similar to a parent support group meeting, is that I always remind them or tell them that it's okay to be their baby's advocate. That they don't need to be worried about sort of rubbing anybody the wrong way or stepping on toes, that this is their child, that they're the parent, and that, you know, just because their baby is newborn and not a 10-year-old who they've established this relationship with for a decade, they're still that child's parent, and that it's always okay to speak up, and it's always okay to advocate and ask questions or question things that you don't understand. So I think that is something we can take with us every day to work, because it doesn't just have to be reminded in a setting like a parent exchange program, but every day you meet a new NICU parent, or someone seems particularly stressed or questioning their care, or maybe having mistrust in care, to remind them that it's okay to be their baby's advocate.
I think that gets back to this habit that we have in medicine too, of labeling families or parents as difficult. And I think that's something that we probably need to be very intentional about stopping, for multiple reasons. But difficult can mean difficult. So I'm not advocating for, you know, abusive behavior, but difficult for me, I feel like normally is referring, when I've heard it, to parents who are advocating and maybe don't have that medical background to, they feel frustrated, I think, because they don't know the terms to use and they don't know the routes to go. And I imagine that if we were a bit more compassionate and a bit more willing to sit and listen and take time, that potentially that difficult nature might turn not difficult and turn into a really valuable communication. And I'm guilty of this too. I'm not trying to say that I've never had that thought cross my mind. But I think it's something that just like we talk more about recognizing biases in healthcare in general, I think that that is a bias that is not probably discussed enough that we need to recognize.
Can I add something to that?
Absolutely.
Yeah. So I think I 110% agree with what you just said. One term I've heard, so there's difficult families, but there's also something called NICU-itis, right? Where, like, okay, the family's frustrated and it's kind of pointed as a label more than like, hey, this family's going through a lot. They may need more help. They may need no support. Again, I'm not advocating for families being violent, abusive, saying harsh things. Like, I'm not advocating for that at all. And they need to have a acceptable behavior to share their emotions that they are feeling. At the same time, when we label things, it makes us harder, not just for ourselves, but then if we label other providers, other staff, may view them in a different light. So just instead of seeing that as like, hey, let's kind of distance ourselves, realize there's probably a lot of things that are going, a lot of emotions that they're experiencing that they may not know that they're experiencing, or they may not understand what they're going through, but really they could use a lot of help and support.
There's been quite a bit in the chat about this idea of peer-to-peer support as well. And I'm wondering if any of you had the experience of peer-to-peer support or buddy support while in the NICU, and if that is helpful, kind of what your thoughts are on it.
I sort of did it ad hoc after, so like when our daughter had HIE, then I basically like told all of my colleagues, I was like, if you have a family who has a kiddo who gets cooled, put them in touch with me and I'll help them. And so I had that happen a couple of times, and I developed some really wonderful relationships with like other families who had kids with HIE. And it was very nice. And somebody actually reached out to me when my daughter was born, who had a child with HIE who was like in Oregon somewhere. And so I received some of that support, and then I was able to do that. And I think it can be very healing to be able to offer support to another family who's going through something similar.
I think from my end, I think reading the chat, it gives me a lot of hope that, like, hand to hold and hope for HIV, all these support groups, there's more recognition. We were in the NICU about a little less than a year and a half ago, and really they're like, oh yeah, there's probably some support groups, and it was talked very vaguely, or like a peer-to-peer support, but we didn't get any resources. We didn't know any names of it, and they didn't know any names of that either. So what we ended up doing, I tend to be a little bit more social, but in the waiting area in the NICU, we were able to strike conversations with other parents going through something similar. And that's how we ended up getting like a peer-to-peer support. But otherwise, it was for our experience, it was lacking. But that's why it makes me very hopeful reading the chat that there's a lot more services, there's a lot more recognition, and a lot more resources that you could actively point people to help with that support.
I think this is a big need now too, as we have more hospitals going to private rooms. I don't know about everyone's experience on the call, but having worked in a NICU that had an open bay, it felt like the parents developed much stronger relationships with each other, just through proximity and unfortunately not having much privacy. But now with the private rooms that I know a lot of our NICUs are striving for many good reasons, it does seem like it's very isolating for families. They kind of go into their room and don't have that opportunity to connect as well. And so I'm also excited about how many programs seem to be really focusing on creating these types of buddy programs. I know someone had their hand raised. I think it was Kristen Love, but I don't know if it was on purpose or not because it's down now.
So this is Christy. Thank you so much. I put it down because I didn't know if the question was directed at the panel. So I was like,
Oh,
maybe
no,
I
anyone
shouldn't
can
comment.
answer.
Okay,
Yes, please.
so I was just actually putting it in the chat. I was had the privilege and the honor for 18 years to work at the bedside for family support at Mercy Children's Hospital in St. Louis. I was a mom of 2 preemies. Our son's was our earliest preemie and had 89 days in the NICU. And towards the end of our stay, we met with a family who had been in there several years ago, and just the reassurance, having that companion and someone just showing us more, guiding us what our life is going to be like at discharge is where my passion came to want to be able to help these families. So even though hospitals like mine at the time had these programs to offer, we also have to remember that we need resources to offer our families. Like, we could offer this amazing support for our families while they're in the NICU, but when they get discharged, again, one of the reasons why I put it in our chat about the guidelines for discharge planning is because I was fortunate enough, I was at our hospital 8, 10, 12 hours a day during our NICU stay. I felt very confident, but when I got discharged, I felt like I was totally alone. And so we have to be able to be aware of and provide our families with these services. Otherwise, they are not going to be able to continue with the success that they're having with the families in the NICU. If that all makes sense, sorry.
Absolutely. No, thank you so much for sharing. I really appreciate it. Well, we've had a great discussion today. Thank you so much to our family partners for participating and for sharing your stories and really kind of opening up on something that I know is probably difficult to talk about on many levels. So please know how much we appreciate you. We do have another webinar that's coming up in November. It will be on November 10th, the same time. So 11 a.m. Pacific time, 2 p.m. Eastern time. And we'll be discussing specifically the need for mental health professionals in the NICU, ways to support parents in your local NICU, and then the power of peer support at a national level. So a nice segue after our discussions that we've had today. You can access information on how to join that webinar through the QR code that's on that flyer here. And then we also have a second QR code to complete an evaluation, which, if you have a chance, please, we really get a lot of utility out of your responses for this. So thank you all for joining. I really appreciate it. And we hope to see you November 10th. Thanks.
Thank you, everyone.